Hello, my name is Manoj Kesarvani, and I'm an interventional cardiologist here at the UC Davis School of Medicine. I serve as the instructor of record for the IMD 420D course in the cardiovascular system. This lecture is entitled Acute Coronary Syndromes. It serves as an important topic in the coronary artery disease module. The objectives of this lecture on acute coronary syndromes include a review of the pathogenesis of the spectrum of acute coronary syndromes, particularly in terms of coronary thrombosis. We will discuss the clinical features of acute coronary syndromes with particular emphasis on diagnosis based on history and physical exam, biochemical changes, and ECG findings. It will be important to describe the treatment of acute coronary syndromes in terms of guideline-driven medical therapy in the context of early invasive and ischemia-guided approaches. I want to make sure that the learner understands the complications associated with myocardial infarction, including mechanical ones. Acute coronary syndromes represent a spectrum of disease. In this hypothetical example, we have a patient that has a high-grade lesion in the mid-left anterior descending artery. This patient may develop a ST segment elevation myocardial infarction, which is characterized by myocardial necrosis. It's due to a completely occlusive thrombus. So shown here, that thrombus is blocking off the artery completely. It's resulting in a 100% stenosis. A ST segment elevation myocardial infarction results in a transmural infarct. A transmural infarct refers to full thickness involvement of the myocardial wall. And on 12-lead ECG, as you well know at this point, we see an ST segment that's elevated. Now, we also have a non-ST segment elevation myocardial infarction that can take place in this patient, and that is also characterized by myocardial necrosis. However, where it's different in terms of a ST segment elevation myocardial infarction is that an NSTEMI for short is due to a partially occlusive thrombus. It results in a subendocardial infarct, and so only the subendocardium is involved. So there's no transmural involvement. It's only involving the subendocardium. In contrast, we have unstable angina, where there's a lack of myocardial necrosis. This also can be due to a partially occlusive thrombus. It typically involves the inner one-third of the subendocardium, which is particularly vulnerable to myocardial ischemia. So let's talk more about acute coronary syndromes in the context of a myocardial infarction as opposed to unstable angina. So myocardial infarction is distinguished by objective evidence of injury, objective evidence of myocardial injury, as confirmed by a characteristic rise and fall in serum biomarkers. So in terms of this hypothetical patient who has a high-grade lesion in the mid-left anterior descending artery, we would expect that the anterior wall would be affected. And so let's explore that in a little bit more detail. So on the y-axis, we have cardiac troponin, a marker of myocardial necrosis, myocardial injury. And on the y-axis, we have time from onset of symptoms in hours. So if we were to draw a cardiac troponin, which is a simple blood test, early on after the onset of symptoms, we will see that it's still in the normal range. But if we're able to continue to obtain cardiac troponin levels, we'll see that it will rise above the 99th percentile of the upper limits of normal, which would be consistent with a myocardial infarction. And over time, as we continue to draw cardiac troponin levels, we'll see that it will rise well above that 99th percentile. And then over time, as we do later sampling, we'll see a peak. And then as we do very late sampling, we'll start to see a fall. So this characteristic rise and fall in cardiac biomarkers, in this case cardiac troponin, is consistent with an acute myocardial infarction. Now, in certain situations, as we'll discuss briefly later in this lecture, patients have chronic myocardial injury, which is distinguished from this type of myocardial infarction where there's a rise and fall in the sense that the troponin level is relatively stable, regardless of whether you draw it early or late. So let's talk about important epidemiology as it relates to acute coronary syndromes. Can you believe until the 1960s, the mainstay of therapy for an acute myocardial infarction was prolonged bed rest and reduction of excessive physical activity? So in the 1960s, again, really there wasn't much that we could offer a patient. They had to be in bed and they had to avoid physical activity, which is very different than what we offer or suggest the patient do now. So in the 1960s, the patient was allowed to shower on his own on the 10th day of his hospital stay, and if he survived or she survived, the patient wasn't discharged until 4 to 6 weeks from the initial arrival to the hospital. Unbelievable. So despite the extensive progress that has taken place, more than 1.4 million people are admitted to hospitals in the United States each year with acute coronary syndromes. However, with the adoption of new efficient treatments and prevention in the last decades, it's decreased in-hospital mortality in acute coronary syndrome from 30% to 3 to 8% today. And over the last 20 years, the one-year mortality has been halved from around 22% to 11%. Shown in this graph, we have percent one-year mortality on the y-axis, and on the x-axis, we have time from 1996 to 2014. If you concentrate on the blue bars, which represents ST segment elevation myocardial infarction, we see this trend that was just described, that the percent one-year mortality is being reduced for the most part. And then we see the same pattern in terms of non-ST segment elevation myocardial infarction, where it's also being reduced from 1996 down to the levels it is at in 2014. And we'll talk a lot in this lecture about how important medical therapy is to achieve these targets. We'll also talk about the importance of mechanical revascularization. Without these interventions, we would not be where we are today, though a lot of progress still needs to be made. So it's important to understand that we need to maintain balance in everyday life. When a normal blood vessel is injured, the endothelial surface becomes disrupted and thrombogenic connective tissue is exposed. And we'll talk about that in more detail in a second. So we do have prothrombotic mechanisms that help to maintain balance. And primary hemostasis is the first line of defense against bleeding. And so when we have disruption of the coronary vessel wall, we need to have primary hemostasis that forms a platelet plug. So there's platelet plug formation that prevents bleeding into the bloodstream. And then we have secondary hemostasis, which is mediated by plasma coagulation cascade factors, as you've learned a lot about in your hematology course. Now we'll talk about this briefly, but the purpose of this lecture is not to focus in on the coagulation cascade. On the other hand, we have endogenous antithrombotic mechanisms. These mechanisms result in inactivation of clotting factors, including thrombin, factor 5A, factor 8A, and factor 7 and tissue factor. There's also lysis of fibrin clots, and there's endogenous platelet inhibition and vasodilatation that takes place. So specifically, there's inactivation of thrombin by antithrombin, as shown here, the effectiveness of which is enhanced by binding of antithrombin to heparan sulfate. So heparan sulfate is a medication that we're able to offer a patient that enhances activity of antithrombin, and that results in irreversible thrombin inhibition. In addition, we have inactivation of clotting factors 5A and 8A, as I just mentioned, by activated protein C, an action that's enhanced by protein S. Protein C is activated by thrombomodulin thrombin complex. Now, what we also see is that there's an inactivation of factor 7 or tissue factor complex by the tissue factor pathway inhibitor. And that's what's shown here. The tissue factor pathway inhibitor is inhibiting this process. And then we also, again, have lysis of fibrin clots by tissue plasminogen activator, which we've taken advantage of in terms of fibrinolytic therapy, which we'll talk later about. And then last but not least, there's inhibition of platelet activation by prostacyclin and nitric oxide, and that's shown here. Inhibition of platelet activation by prostacyclin and nitric oxide. So in a normal situation, in you and me, there's maintenance of balance through prothrombotic mechanisms as well as endogenous antithrombotic mechanisms, as was just discussed. Let's now get into more detail and discuss coronary artery atherosclerosis. But before we do that, we should talk about the anatomy of a coronary vessel. And to begin, we have a tunica intima that's composed of endothelial cells with an outer layer that represents the internal elastic membrane. And so again, we have the intimal layer here, and then we have endothelial cells, as shown here. Now we do have some macrophage or monocyte infiltration that's shown here too, but the lumen is lined by endothelial cells. And again, we have this internal elastic lemma as shown here. Then we have the tunica media, which is composed of homogeneous smooth muscle cells, and the outer layer represents the external elastic lamina or membrane, and that's shown here, the external elastic lamina. And then we have the tunica adventitia, which is composed of sheets of collagen, which forms the outer layer of the coronary vessel. Now let's get into the nitty-gritty, if you will, about atherosclerosis. So step 1 refers to the fact that there's accumulation of lipoprotein particles in the intima. The darker color depicts modification of these lipoproteins. So we're going to focus in on LDL. So again, there's accumulation of LDL into the intima, and then there's going to be modification where the LDL is going to be oxidized or glycated. It undergoes glycation, in other words. And then in step 2, what happens is there's oxidative stress. Reactive oxygen species form. This oxidative stress, including constituents of modified LDL, induce local cytokine elaboration. So they're inducing the production of cytokines. And then in step 3, these cytokines promote increased expression of adhesion molecules that bind leukocytes. So increased expression of adhesion molecules that bind leukocytes. For example, they include chemoattractant molecules like monocyte chemoattractant protein 1, MCP1. You won't need to memorize this. I just want you to be aware of this cascade. So MCP1 directly stimulates leukocyte migration into the intima. So we have these monocytes that are now entering through the intima, into the intima, I should say. And now in step 4, after we have entering of the arterial wall in response to the chemoattractants, blood monocytes encounter stimuli such as macrophage colony stimulating factor, MCSF, that augment their expression of scavenger receptors. Now in step 5, these scavenger receptors mediate the uptake of modified lipoprotein particles and promote the development of foam cells. So we're going to have foam cells start to develop. Macrophage foam cells are a source of additional cytokines and effector molecules such as superoxide anion and matrix metalloproteinases. So foam cells, again, are basically macrophages that have taken up oxidized LDL. Now in stage 6, we're really going to focus now on smooth muscle cells. So the smooth muscle cells that make up the medial layer are now going to migrate into the intima, again from the media, which causes increasing intimal thickness. So you can see here versus here, the intima is thickening. And now that you have smooth muscle cells here, these intimal smooth muscle cells divide and elaborate extracellular matrix, promoting matrix accumulation in the growing atherosclerotic plaque. Now, stage 8, finally, in these later stages, calcification can occur. So this calcification occurs because the smooth muscle cells become osteoblasts-like cells and actually produce calcium in the artery. So the plaque hardens. It's soft with the oxidized LDL, but it hardens with calcification. And fibrosis continues as well, sometimes accompanied by smooth muscle cell death, including programmed cell death or apoptosis, as you know. yielding a relatively acellular fibrous capsule surrounding a lipid-rich core that may also contain dying or dead cells. We'll often refer to this as a necrotic core. So at this step, a fatty streak evolves into a fibrofatty lesion. So shown here is a fatty streak. And that's associated with endothelial dysfunction, lipoprotein entry and modification, leukocyte recruitment we've talked about, and certainly foam cell formation. So this can develop as early as in the 20s. And then when we go from a fatty streak, we undergo plaque progression. And we talked about that smooth muscle cell migration that takes place. We talked about how there's production of or elaboration of the extracellular matrix, and there's a lipid core that forms, a necrotic core. And then finally, when we have an acute coronary syndrome, there's plaque disruption. The intima ruptures. There's plaque rupture. And so there's disruption of the plaque integrity, and thrombus can form. So let's put atherothrombosis together. So when a patient undergoes atherosclerosis, as we described in the previous slide, what can happen is that a patient can undergo plaque rupture, or the plaque can undergo plaque rupture. Now, plaque erosion can take place too, but plaque rupture more commonly results in acute coronary syndrome as compared to plaque erosion. And so when we have plaque rupture, we can have interplaque hemorrhage related to the vasovasorum, as we'll talk about, which decreases the vessel lumen diameter and which can contribute to coronary thrombosis. We also talked about 2 slides ago about how there's a release of tissue factor. The release of tissue factor results in the activation of the coagulation cascade. Additionally, there's exposure of subendothelial collagen, which activates platelets and results in aggregation, which we'll talk about later in this lecture. There's also turbulence of flow, which can also result in platelet activation and aggregation. And with this platelet activation and aggregation, we can get coronary thrombosis. And then we can get a dysfunctional endothelium, which results in a decreased vasodilator effect, such that there's now vasoconstriction, so making that stenosis even worse and resulting in coronary thrombosis. There's also a decrease in antithrombotic effect associated with a dysfunctional endothelium that also results in coronary thrombosis. So all of this together, the final common pathway is coronary thrombosis. Now the vulnerable plaque. So in the past, we talked a lot about the fact that the underlying cause for an acute coronary syndrome is plaque rupture, but it's plaque rupture of the so-called vulnerable plaque. So shown here is a normal artery. That vulnerable plaque is the thin cap fibroatheroma, the thin cap fibroatheroma. That's what we frequently think of as a vulnerable plaque. So this is a rupture-prone plaque with a large lipid core, a necrotic core, and then a thin fibrous cap is shown here, a thin fibrous cap is shown here that's infiltrated by macrophages, as we talked about in the previous slides. And so for the longest time, we really thought that was a major vulnerable plaque responsible for the majority of acute coronary syndromes. But over time, we understand that there are many different types of vulnerable plaques. So we also have a ruptured plaque with subocclusive thrombus and early organization. That's shown in Figure B. Figure C shows an erosion-prone plaque with proteoglycan matrix, so that's extracellular matrix material, and a smooth muscle cell-rich plaque. And then we can have an eroded plaque with subocclusive thrombus. Moving on, we can have interplaque hemorrhage secondary to leaking vasovasorum. So remember, the vasovasorum is a blood supply for the coronary vessel. And then here we have a calcific nodule. So again, that smooth muscle cell has now differentiated into an osteoblast-like cell and it's produced calcium, and it's a calcific nodule. So this nodular calcific area protruding in the vessel lumen that can be particularly difficult to treat by percutaneous coronary intervention. And last but not least, we can have a chronically stenotic plaque with severe calcification, old thrombus, and an eccentric lumen, such that the lumen is just really small. Now let's talk more about the thin cap fibroatheroma. So the thin cap fibroatheroma is characterized by a thin fibrous cap as characterized by less than 65 microns with macrophage infiltration. So that's shown here. So this is a thin fibrous cap that's less than 65 microns that's infiltrated by macrophages. This thin cap fibroatheroma also has a large lipid-laden or necrotic core that's frequently eccentric. Eccentric means it's on one side of the vessel, as shown in this cartoon. What we also see is there's intimal neovascularization with vasovasorum proliferation. And again, this type of plaque is prone to plaque rupture or erosion. Again, we talked about how plaque rupture occurs more frequently than plaque erosion and is more commonly responsible for an acute coronary syndrome. Now, here's a histology slide or histologic section of a thin cap fibroatheroma, which I want you to be able to recognize because it does appear on step 1. I also have shown here an image of intravascular ultrasound. So when I perform a percutaneous coronary intervention as an interventional cardiologist, I can actually place an intravascular ultrasound probe into the coronary artery, and I can also demonstrate that a plaque has a thin fibrous cap. But in this example, the fibrous cap is 100 microns, so it's greater than the 65 microns. So technically, it's not a thin fibrous cap, though it's very close in morphology to that. And again, we see a necrotic core based on ultrasound properties of a foam cell. So it's important to understand that in everyday life, there's an interplay between thrombosis promoting and resisting factors in the epicardial coronary artery. So shown here is an example where a patient undergoes plaque rupture. So when a patient undergoes plaque rupture, we have a balance between thrombosis promoting factors and thrombosis resisting factors. In this example, the thrombosis resisting factors have greater weight. They have greater influence here. So in this example, there's asymptomatic plaque healing and not vascular thrombosis or an acute coronary syndrome. And vascular healing, by and large, occurs more commonly. However, we can have the opposite situation where a patient can undergo plaque rupture where thrombosis promoting factors have more importance as compared to the thrombosis resisting factors. In this case, vascular thrombosis will take place and a patient will suffer an acute coronary syndrome. And again, this occurs less commonly. Vascular thrombosis occurs less commonly, but it's this imbalance, I should say, rather than a balance, that's responsible for an acute coronary syndrome. Moving on now, I want to make sure that you appreciate the fact that there are changes in the concept of coronary artery disease. So we just talked about the idea of the vulnerable plaque concept. But prior to that, we really got excited, if you will, about a coronary artery stenosis and focused in on that in order to detect it and treat it. So in the 1980s was when angioplasty and percutaneous coronary intervention, in other words, stent placement, really started to take off and has really progressed over the last 40 years. Once we started to do PCI and started having imaging technologies to be able to define that plaque, but more commonly looking at pathology, looking at patients who died from sudden cardiac death and recognizing that there was a vulnerable plaque, particularly in the form of a thin cap fibroatheroma, we got excited about this concept. But then our thinking evolved. We started thinking about myocardial ischemia and decided that that should be a focus of detection and treatment. If a patient had evidence of myocardial ischemia, we got to detect it with the various stress tests we talked in other lectures about and treat it. Then we recognized a very important point that inflammation is a very key player in terms of disease activity and risk. And then we moved away from the vulnerable plaque concept to the idea of a vulnerable patient, that a patient could have a large burden, global burden, I should say, of coronary artery disease, and we shouldn't just focus in on one thin cap fibroatheroma, and we should look at all the coronary vessels and think about how much atherosclerosis burden there is in that given patient. Then we talked a little bit more about coronary physiology, and much the way that we talked about in the first lecture. And so we started thinking about being lesion specific and using various modalities like fractional flow reserve, which is my clinical and research interest, to help drive treatment. Then moving on, we thought about clinical and subclinical atherosclerotic disease, detecting disease before a patient has an adverse outcome such as a myocardial infarction or unstable angina. And then finally, in 2020, we're very patient-centered as compared to being lesion-focused, and we think about the ACS event risk in terms of a triangle, where the top of the triangle we think about atherosclerotic disease burden, and then we also think about atherosclerotic disease activity, and then we also think about the prothrombotic milieu. And together we use that to assess ACS risk in a given patient, where we're focusing in now on early detection and prevention, and less on coronary revascularization, although it's very important. We want to detect coronary disease early so coronary revascularization does not become necessary. So let's summarize. In the previous slides, we've talked a lot about the concept of atherosclerosis and coronary thrombosis. Let's just make sure we're all on the same page. So the left figure illustrates the progression of plaque formation and onset of a non-ST elevation acute coronary syndrome. A non-ST elevation acute coronary syndrome. So that would be an NSTEMI or unstable angina. So the number section of an artery depicts the process of atherogenesis from a normal artery is depicted in 1 to extracellular lipid in the subintima to the fibrofatty stage to procoagulant expression and weakening of that fibrous cap. And then finally, acute coronary syndromes develop with disruption of the fibrous cap, which is a stimulus for thrombogenesis. And then there can be thrombus resorption, followed by collagen accumulation and smooth muscle cell growth, which narrows the artery even more and can cause ischemic pain. Now, the right figure illustrates the clinical, pathological, electrocardiographic, and biomarker correlates in an acute coronary syndrome. So flow reduction may be related to a completely occlusive thrombus, as in an ST semi-elevation myocardial infarction, or subtotally occlusive thrombus, as seen in an NSTEMI or unstable angina. Now, most patients with a STEMI, ST semi-elevation myocardial infarction, are going to develop a Q-wave myocardial infarction. So on the EKG, on the ECG, we will see evidence of a pathologic Q-wave, but a few will develop non-Q-wave myocardial infarction. So what a Q-wave represents typically is a transmural infarct. So in some cases, even though you have an occlusive thrombus and a patient has suffered a ST semi-elevation myocardial infarction, it may ultimately only result in a non-Q-wave myocardial infarction. So in those patients without ST elevation, they have either unstable angina or an NSTEMI, a distinction based on cardiac biomarkers that we'll emphasize a little bit later, though we have talked about it already. So most patients presenting with an NSTEMI will develop a non-Q-wave myocardial infarction, though a few of them may end up developing a transmural infarct and will have Q waves on their ECG. And so the spectrum of clinical presentations, including unstable angina and STEMI is referred to as acute coronary syndromes. Patients with non-cardiac etiologies make up the largest group presenting to the emergency room, even here at UC Davis, with chest pain. Let's move on and talk about the diagnostic evaluation of acute coronary syndromes. Of course, that begins with history and physical examination, or the patient's presentation. So we're really going to think about the clinical setting of the symptoms and vital signs in the patient's presentation, where if a patient has pinpoint chest pain, as depicted by just an index finger, we're going to think less so of that representing acute coronary syndrome as compared to a patient having substernal chest pain or chest pain radiating into the jaw or into the left arm or even into the right arm. And we get especially concerned in those patients that have an out-of-hospital cardiac arrest where they may need CPR or they may develop a condition called cardiogenic shock. The next part to this is that we're going to pay attention to the 12-lead ECG. If we see ST summit elevations, then we're going to be concerned for an ST summit elevation myocardial infarction. Whereas if we see ST depressions, that are severe or mild, we're going to think about non-SC segment elevation acute coronary syndromes like an NSTEMI or unstable angina. But we're also going to pay attention to serum biomarkers. What's really gained a lot of traction as of late are the high sensitivity cardiac troponins, as abbreviated as shown here. And we need to check them initially when a patient arrives, as well as 1, 2, or 3 hours after they arrive, because there are characteristic rise when patients have myocardial infarction, as we depicted in previous slides. So we're going to really pay attention to this. And we're going to determine whether we're able to rule out a myocardial infarction and even rule out unstable angina, and may describe the patient as having a non-cardiac cause for chest pain. But a patient may very well end up developing unstable angina. They could have other cardiac disorders that we're really concerned about, such as an aortic dissection, where patients typically will have chest pain radiating in the back that's described as a tearing sensation, so we don't want to miss that diagnosis. Or they can truly have a myocardial infarction, which is characterized by that rise in the cardiac biomarkers, elevation in the troponin as shown here, again, resulting in either an NSTEMI or STEMI. And now shown here is a diagram from the European Society of Cardiology guidelines just showing that in a given population, we have to have concern for a myocardial infarction. And the first step in that evaluation is going to involve a 12-lead electrocardiogram, maybe on the field, but also in the emergency room. What I mean by in the field is when a patient is being evaluated by emergency medical services. And so once a patient's in the emergency room, we're going to repeat that ECG. We're going to draw cardiac biomarkers as well as other laboratory tests, and we're going to make a decision about whether the patient does indeed have an acute coronary syndrome or not. So let's talk more about the clinical presentation that you will encounter typically when a patient is suffering an acute coronary syndrome. So frequently, patients will describe a prolonged chest discomfort at rest. Prolonged meaning greater than 20 minutes. We'll sometimes refer to this as rest angina. Another situation that may come up is a patient may have new onset or de novo angina. When we say de novo, we mean within the last 3 months. And we use, again, the Canadian Cardiovascular Society distinction of class 2 or 3 or greater angina. It's 2 or 3 or greater angina. Now, if a patient has a recent destabilization of previously stable angina with at least Canadian Cardiovascular Society class 3 angina characteristics, in other words, crescendo or worsening angina, we're going to be concerned about an acute coronary syndrome in that patient. And of course, in a patient that has had or is suffering post-myocardial infarction angina. So if a patient had a recent myocardial infarction, such as an NSTEMI, there may be some residual myocardium in that distribution that's at risk for ischemia. In such a way, a patient may develop an acute coronary syndrome again. So this is a figure that you're familiar with from our team-based learning session on unstable angina that has been modified for acute coronary syndromes. So when a patient is potentially suffering a myocardial infarction or is indeed suffering a myocardial infarction, there can be a decrease in systolic function depending on which artery is involved or what muscle is involved, which can result in uncoronated mechanical activity or a patient may have a dyskinetic apical impulse. This decrease in systolic function can also result in pulmonary congestion, and on exam, a patient may have rales or crackles. Again, a patient can have decreased compliance of the left ventricle that results in pulmonary congestion and crackles as well. This also can result in an S4 gallop. Papillary muscle dysfunction is also a possibility with myocardial infarction, particularly if it involves the posterior lateral papillary muscle, because that has a single coronary artery supply, typically the right coronary artery, as compared to the anterior lateral papillary muscle. These patients will suffer mitral regurgitation that we can auscultate on exam. Definitely in a myocardial infarction, patients will have increased sympathetic tone, as manifest with diaphoresis, an increase in heart rate, as well as an increase in blood pressure. There can also be an increase in parasympathetic effect that results in nausea, vomiting, and weakness. Now shown here are the classes of angina as based on the Canadian Cardiovascular Society. So class 3, we said there's a marked limitation of ordinary physical activity as compared to class 2, where there's only slight limitation of ordinary activity, whereas class 4 angina patients have chest pain at rest. And then class 1 angina patients have angina only with more severe activity. With ordinary physical activity, they're able to carry on without issue. Now, there certainly is a differential diagnosis when we're thinking about acute coronary syndromes. So when you think about cardiac possibilities when we're considering acute coronary syndrome, we want to think about myopericarditis, as we talked about in our stable angina talk. We also want to consider cardiomyopathies. We want to think about tachyarrhythmias, as we'll learn about later. Even acute heart failure can mimic an acute coronary syndrome. Hypertensive emergencies, aortic valve stenosis, as we'll learn about next week. Patients can have a stress-induced cardiomyopathy known as Takotsubo syndrome, which we're seeing an increase of in the COVID-19 pandemic, unfortunately. Patients can also have coronary spasm in the way that we talked about in our stable angina team-based learning session, and cardiac trauma. Pulmonary-wise, we want to consider a PE, a pulmonary embolism, or a tension pneumothorax, bronchitis, atypical pneumonia, pleuritis. When we're considering vascular causes in the differential diagnosis, we do not want to miss a diagnosis of an aortic dissection, which can be fatal. Or a patient could have a symptomatic aortic aneurysm. They could even have a stroke. Gastrointestinal symptoms include esophagitis, reflux disease, or esophageal spasm, peptic ulcer disease or gastritis, inflammation of the stomach wall, pancreatitis, cholecystitis. And then orthopedic-wise, we want to make sure we don't miss musculoskeletal disorders, such as chest trauma, costochondritis, muscle injury or inflammation. Even cervical spine pathologies can radiate to the chest. And of course, we want to treat the whole patient. We don't want to miss anxiety disorders. We want to consider infectious possibilities like herpes zoster, anemia. And so some key points when we think about a differential diagnosis. We want to consider that coronary artery disease results in a chest pain syndrome precipitated by activity and relieved by rest. So when we're questioning a patient in the emergency room, when we're considering an acute coronary syndrome, we want to ask questions about whether the patient has or had chest pain that is precipitated by activity and relieved by rest. And maybe there's a progression where maybe a couple of weeks ago it was only happening with activity and now it's happening at rest even. So that would be the crescendo angina. We also want to make sure that we're determining whether the chest pain is caused by movement or is reproducible palpation. If it's reproducible palpation, we might consider really costochondritis as a possibility. Now, chest discomfort associated with food, nausea, or vomiting does not necessarily exclude coronary artery disease. As we talked about in that stable angina team-based learning session that I subsequently recorded, we mentioned how when patients eat food, that what happens is that there's splanchnic vasodilation. There's shunting of blood to the stomach where it's needed. And when there's shunting of blood to the splanchnic circulation, if a patient has a high-grade stenosis in the coronary artery, it can induce coronary steal. And in that patient, they will have angina symptoms. I will admit, typically in that scenario, those patients will also have chest pain with physical activity, but the possibility does exist that patients can have chest pain with eating associated with coronary artery disease. And last but not least, it's important to remember that response to organic nitrates, such as sublingual nitroglycerin, does not necessarily rule in or exclude coronary artery disease. Now, we talked about how the 12-lead ECG is an indispensable tool in the evaluation of acute coronary syndromes. So this is beyond the scope of this lecture. It will definitely lengthen this lecture if we go into too much detail in terms of 12-lead electrocardiogram. So please refer back to your lectures on ECGs and acute coronary syndromes that was given by Dr. Venugopal. And then, of course, refer back to your ECG small group session for further details. I do want to mention that the 12-lead ECG should always be the first diagnostic step in management of a patient with chest pain. So when they arrive to the emergency room, it should be the first diagnostic step. Not necessarily treatment step, but diagnostic. There's no treatment really offered in the ECG, though it will help establish a diagnosis. Now going to these figures, when we're considering unstable angina or an NSTEMI, we want to remember when we have a normal QRS, when we're looking at the QRS complex and a T wave, what can happen acutely is that we can notice a T wave inversion. So when a patient is undergoing myocardial ischemia or infarction, when we're concerned about NSTEMI, we may see a T wave inversion. And then weeks later, they may normalize. Or when the chest pain episode is resolved, that may normalize. Or alternatively, we may see some SC segment depressions also occurring when the patient is having episodes of chest pain. And that may also normalize over time. And again, emphasizes the idea that typically we do not see Q waves associated with an NSTEMI. We certainly would not expect Q waves with unstable angina. We would not expect Q waves with unstable angina because of the fact that Q waves represent transmural infarction. And with unstable angina, we do not expect infarction because of the fact that cardiac biomarkers will be negative. They will not be elevated in the bloodstream because infarction hasn't taken place. Now moving over to the right, for a STEMI, we want to remember that there's an evolution that takes place. So again, here's a normal situation where we're concentrating on the QRS complex, the ST segment, and the T wave. So acutely, we'll see ST elevations. I should also mention that right away when a patient develops an acute STEMI, you might even notice what are called hyperacute T waves. Hyperacute T waves refer to peak T waves. Peak T waves have a very high amplitude and a narrow base. So that might even precede an ST elevation. We don't want to emphasize that heavily in this course, and it's not something that you'll be tested on, but it's an important tidbit to be aware of. Now, after we have an ST elevation acutely, what we'll see as soon as hours is that we'll continue to see the ST elevation. We'll see a decrease in the R wave, and the Q wave will start to form. So Q wave will already start to form, representing that transmural infarct. Although it may not be quite pathologic, it's starting to form. And then 24 to 48 hours later, we'll see T waves inversions here, and the Q wave gets a little bit deeper as that transmural infarct develops. And then days later, the SC segment normalizes, the T wave inverts, it stays inverted, it's not as deep. And then weeks later, we'll see that T wave normalizes, the ST segment has already normalized, it did previously, it stays normalized, and that Q wave persists. And that Q wave, particularly the upright T wave, represents an old myocardial infarction. Now, when we're considering acute myocardial infarction and we're seeing it evolve, we really want to consider serum biomarkers. So serum markers of infarction are really important to consider. So let's first begin with creatine kinase. The enzyme creatine kinase is found in the heart, skeletal muscle, brain, and other organs. Injury to any of these tissues may lead to elevation in serum concentrations of this enzyme. However, we really want to focus in on creatine kinase MB isoform. This form is localized mainly in the heart. So it starts to rise 3 to 8 hours following a myocardial infarction. So we refer to this figure, what we have here on the x-axis is days after the onset of acute myocardial infarction. So day 0 all the way out to day 9. And then on the y-axis, we have multiples of the upper limits of normal in terms of these various cardiac biomarkers. So again, CKME starts to rise 3 to 8 hours following an MI. So that's shown in the green curve here, in the CKMB isoform. We see that it starts to rise 3 to 8 hours following an MI. It peaks at 24 hours following MI. So by day 1, it's already peaked. And then it returns to normal within 48 to 72 hours. So by day 2 to 3, it gets back to normal post-MI. So it can be helpful in differentiating reinfarction, and that'll become clear in a second. So troponin is an important regulatory protein in muscle cells, as you know, that controls the interactions between myosin and actin. Remember that first lecture. Also, it's in chapter 1 of your textbook. So it consists of 3 subunits: troponin T, troponin I, and troponin C. So all these subunits are found in both skeletal and cardiac muscles. The cardiac forms of troponin I and troponin T are structurally unique and used widespread in various assays. We don't have an assay for troponin C, so we're really focusing on troponin T and troponin I. So what's important to remember is that cardiac troponin T or troponin I are more sensitive and specific than CKMB. Again, they're more sensitive and specific than CKMB. So they can be detected as early as 2 to 4 hours after symptom onset, but the elevation can be delayed up to 8 to 12 hours. The issue is that they may not be in the abnormal range very early on. And so that becomes an issue. And so, again, what we're seeing is that they rise, and they may stay elevated above the upper limits of normal for 7 days or more after an acute myocardial infarction. So what's shown here is that they may reach their peak within 48 hours. And now what I want to point out is why CKMB isoforms can be very helpful for differentiating reinfarction, because it takes all the way up to 7 days for that troponin level to normalize. If a patient has a reinfarction, it's going to be really difficult to determine if that troponin is rising again. So CKMB will very clearly rise if a patient has a reinfarction, let's say on day 4, and we can detect that. Now, what's also shown here is that patients can have a small myocardial infarction, and that's shown here in this curve, a small myocardial infarction. This is shown as a large myocardial infarction where there's a very dramatic rise. And that's another important feature to remember, is that the amount of troponin being released into the bloodstream as detected by these assays is proportional to the size of the myocardial infarction. And so that has a lot of prognostic value. With that said, the magnitude of the troponin elevation is not used to differentiate between an end-STEMI and STEMI, though typically we would expect a STEMI to be associated with a large myocardial infarction, but it's not used to differentiate the two. Now let's talk about high-sensitivity cardiac troponin, which has gained a lot of traction. It's used here exclusively now at, again, UC Davis Medical Center. So it provides the same information as conventional cardiac troponin assays, so the conventional troponin T, troponin I assays. Again, it provides the same information as those if the concentration is substantially elevated. In other words, if it's greater than 100 nanograms per liter. And we'll explore that in a little bit more detail. But it has a higher negative predictive value. In other words, it allows a precise differentiate between normal and mildly elevated. So we can tell the difference between normal and mildly elevated with a high sensitive cardiac troponins, as the high sensitive name would suggest. So let's explore that in a little bit more detail. So here's again another figure. And so with the conventional assays, we had the range of normal. And so with the conventional assays, that what happens is when a patient has an acute myocardial infarction, there can be a slight rise in troponin that with the conventional assays is not detected because it's still in the normal range. And in fact, we have an area where we can't even detect with the conventional assays the troponin levels. And then as they start to rise dramatically, that's when we know it's pathologic. Now, when we go from a conventional assay, the units are different. There are 1,000-fold higher as far as the units, and we use nanograms per liter. And so in terms of the high sensitivity assay now, what we're doing is that we're able to detect in this normal range what the troponins are doing. And actually, if we see a magnitude increase of even 4 nanograms per liter, that's a rise that we get concerned about. And so shown here is that the limited detection is, depending on the assay, ranging from 1 to 5 nanograms per liter, which is remarkable compared to the old assays. And once it gets to greater than the 99th percentile in terms of the upper limits of normal, that's where it's pathologic. And so we have a much larger range here of pathology in terms of troponin compared to the conventional assay. So some key points about this is that With a high sensitivity assay, we're able to reduce the troponin blind interval, leading to earlier detection of acute myocardial infarction. So if we have a patient sitting in the emergency room, we're able to detect much earlier on whether they're having an acute myocardial infarction or not. So we can make a triage decision about whether they can go home or whether they need to undergo more observation. The other thing to remember is that the high sensitivity assay results in a 4% absolute and 20% relative increase in the detection of what's called a type 1 myocardial infarction. So a traditional myocardial infarction in the way that we've talked about, an NSTEMI or STEMI, and a corresponding decrease in the diagnosis of unstable angina. So you can imagine with the conventional assays where we may have some difficulty in detecting cardiac biomarkers, that now when we have a high sensitivity assay where it's easier to detect a rise in cardiac troponins, that we're going to clinically have less unstable angina because of the differences in the assay. One last thing I want to say is that biomarkers complement clinical assessment in the 12-lead ECG and the diagnosis, risk stratification, and treatment of patients with suspected non-ST segment elevation acute coronary syndrome. With a STEMI, we have to remember that that's a medical emergency. So with a STEMI, we cannot wait for the cardiac biomarkers to return from the laboratory. So frequently, we're making a decision based on clinical assessment and the 12-lead ECG clearly showing ST segment elevation myocardial infarction. So moving on now, I'm going to give you a review question. This is review question 1. So here we have a 78-year-old woman with history of coronary artery disease and prior revascularization by percutaneous coronary intervention, in other words, stent placement, of the right coronary artery, who presents to the emergency department with complaints of substernal chest pain and shortness of breath. She states that she has been feeling tired and weak for the past 7 days. So on physical exam, she's pale with a heart rate of 110 beats per minute, so she's tachycardic, it's greater than 100 beats per minute, and the blood pressure is on the low side, it's 80 over 50 millimeters of mercury. Routine laboratory tests are significant for a hemoglobin of 4.7 grams per deciliter. Normal is greater than 12 grams per deciliter. So this patient is dramatically anemic, severely anemic. In addition, the decision was made to obtain serial high-sensitivity cardiac troponins, where the normal range on this assay is less than 14 nanograms per liter, and they're elevated. Initially, it's 75 nanograms per liter. 1 hour later, it's 74 nanograms per liter. And then 3 hours later, it's 75 nanograms per liter. So there's no rise and fall. They're really flat. So the question we want to ask you is, which of the following is the most likely explanation for this patient's chest pain? Is it A, that there's total thrombotic occlusion in a coronary artery that developed due to plaque rupture of a thin fibrous cap atheroma with necrotic core? Or is it B, coronary vasospasm? Or should we see a better option? Partially occlusive thrombus in a coronary artery that developed due to superficial erosion of a thin fibrous cap atheroma with necrotic core? Or is there a mismatch of myocardial oxygen supply and demand without plaque rupture or erosion or associated thrombus? So I want you to pause the video to take a second to answer this question. It's a very challenging one that really tests your understanding of acute coronary syndromes and also the concept of myocardial oxygen supply and demand. It was a question that appeared in the midterm last year, where students for the most part did not do as well as expected. So let's take a second here and think about the answer to this question. So first, let me say, we've talked about a type 1 myocardial infarction to date here. We talked about the fact that in a hypothetical patient, if they have a left anterior descending artery that has a high-grade stenosis, what can happen is if there's plaque rupture or erosion, there can be a completely occlusive thrombus that will then result typically in a ST segment elevation myocardial infarction. Or alternatively, a patient can have plaque rupture or erosion that results in a non-occlusive thrombus. And in that case, that will result in either a non-ST segment elevation myocardial infarction if there's evidence of myocardial infarction based on the cardiac biomarkers being elevated, or unstable angina where the cardiac biomarkers are not elevated. But the key idea here in a type 1 myocardial infarction, which we want you to focus on for this course, is that there's plaque rupture or erosion. Now what I want you to think about is myocardial oxygen supply and demand. Now we know when a patient has an occlusive thrombus that certainly there's going to be a change in terms of supply. But let's talk more about supply. We talked previously how myocardial oxygen supply is related to O2 content. So it's related to the amount of oxygen being delivered in the blood, in red blood cells. And that in turn is dependent on coronary blood flow. So we think back to the answer to this question in this patient. We talked about how the patient's blood pressure was on the low side, 80 over 60 millimeters of mercury. So we talked about diastolic pressure being synonymous with coronary perfusion pressure. So that's low. So that's of concern. And then the other part to this that's a little bit more complicated is that the patient is severely anemic. So the amount of oxygen bound to the hemoglobin in this patient is a lot less if this patient's hemoglobin was normal. I should say the amount of oxygen being delivered is a lot less. And here, there are no issues really in terms of demand in this patient. There was really no change in terms of wall stress. Well, I should say that the heart rate was increased, so certainly there's an increase in myocardial oxygen demand related to that. And for the most part, we don't really think about a change in terms of contractility. But what I really want you to think about is that there is definitely a decrease in terms of myocardial oxygen supply. So let's think about this a little bit more. So let's ignore the possibility that this patient could have plaque rupture or erosion. We know there's a whole set of conditions that can affect myocardial oxygen supply and demand. They include hypoxemia, hypotension, as suffered by this patient, also cardiogenic shock, which we'll talk about later, kidney disease, heart failure, ventricular tachyarrhythmias, even simply sinus tachycardia, and anemia. Now, in any one of these conditions, if it's severe, it can result in myocardial injury where there's an increase in cardiac troponins. But if it's not severe, we won't see any myocardial injury, so the troponins will be normal. Now, if it's really severe, we may even see evidence of myocardial infarction. So we might see ECG changes, such as ST segment depressions. We may see T-wave inversions. But we wouldn't expect ST segment elevations because ST segment elevations would be only caused by plaque rupture or erosion resulting in an occlusive thrombus. The point here in this example is given the patient's history, we would not suspect plaque rupture or erosion. So that rules out the possibility of a traditional end-STEMI due to, again, plaque erosion or rupture related to a thin cap fibroatheroma, and it also rules out the possibility of occlusive thrombus from a rupture of a thin cap fibroatheroma. So I know this is a complicated question, but what we want you to start thinking about is this idea of a type 2 myocardial infarction, that patients can suffer a myocardial infarction without plaque rupture or erosion taking place, without thrombus forming. So that could happen in a patient that has, for example, a 70% stenosis, where if they have severe hemorrhage, severe bleeding, that can really affect myocardial oxygen supply. And if it's dramatic enough, they will have myocardial necrosis and myocardial infarction. It could also be related to coronary vasospasm, where a patient may not have any stenosis, but with a vasospasm, it creates something like a 70% stenosis. And on top of that, in this given patient, they're having anemia and a drop of blood pressure that can result in myocardial necrosis or infarction. Or a patient can have a non-atherosclerotic coronary dissection. We won't talk too much about that, but that sometimes can happen in a woman that's pregnant. And it can also happen in a patient like yourself that has no coronary artery disease whatsoever, but has a severe stress, such as being involved in trauma where there's significant blood loss that's going to result in myocardial necrosis and infarction because of this dramatic blood loss. And so these processes that refer to myocardial infarction without plaque rupture erosion are referred to as a type 2 myocardial infarction, which this question is testing. Now, this is something that's unlikely to appear on step 1, but it is a question that integrates multiple systems. In this course, we're primarily focused on the cardiovascular system, but it's a good question because it focuses you or forces you to think about other symptoms in the context of coronary artery disease. Now let's move on now and talk about general principles of treatment as it relates to acute coronary syndromes. So when we think about acute coronary syndromes, we want to think about anti-ischemic therapy. This is going to be very similar to anti-anginal therapy that we use for stable angina pectoris. And then we also want to think about antiplatelet therapy. It gets much more aggressive with acute coronary syndromes as relative to stable angina. Then we also want to think about anticoagulant therapy. And then, of course, high-intensity HMG-CoA reductase inhibitors or statins. So in terms of anti-ischemic therapy, you know this already. You know that organic nitrates, such as in the form of sublingual nitroglycerin, are very important in terms of the supply-demand equation. Beta blockers, also calcium channel blockers, we talked about in terms of unstable angina TBL, the value of diltiazem, verapamil, amlodipine, and even nifedipine. And what I've shown here is the effects in terms of heart rate, systolic blood pressure, contractility, and left ventricular volume. So at your leisure, you should make sure you understand all the various changes that take place with these medications, because a table like this frequently appears on the NBME shelf exam as well as step 1. And if you're able to understand why these various medications cause these changes, then it shows that you really understand what we wanted you to really grasp in terms of the stable angina TBL session as well as acute coronary syndromes. So we'll move on now because this is a topic, again, you're very familiar with. And now we're going to talk about antiplatelet therapy. And so we have many medications that are very important in terms of acute coronary syndromes. Let's think about it in terms of platelet within a coronary artery. So as you know, when we think about the cascade of a platelet plug formation, the first step in this process is adhesion. Adhesion is related to some factors I will talk about shortly. But another component to this is activation. Activation is triggered by thrombin binding to the appropriate receptor, as well as ADP binding to the ADP receptor or the P2Y12 receptor. It's also mediated by thromboxane binding to the thromboxane receptor as well. We talked previously about how collagen can also activate platelets. And we'll talk about the role of Linderman's factor as well as fibrinogen shortly. And then aggregation, platelet aggregation. So platelets collecting at the same area of the coronary artery where injury has taken place. And then amplification, where we have platelet plug formation along with fibrin forming. So let's focus in on aspirin. Aspirin is a real foundation for therapy for acute coronary syndromes. As you well know, what aspirin does is that it irreversibly reduces platelet aggregation by inhibiting the COX-1 enzyme, and that's shown here. Aspirin's inhibiting the COX-1 enzyme that's inhibiting the production of thromboxane. And so what happens with platelet degranulation is thromboxane is released, which then binds the thromboxane receptor, resulting in platelet activation. So you're going to have less thromboxane production with aspirin. Now, another important part to the treatment of acute coronary syndromes is we need to think about inhibition of the ADP receptor. So one of the most important medications to be aware of in this regard that frequently appears on step 1 as compared to prasugrel and ticagrelor and cangrelor, which are newer medications, are as follows. So clopidogrel irreversibly inhibits the P2Y12 receptor. We talked in previous lectures about how clopidogrel undergoes a 2-step oxidation process. So clopidogrel, again, is inhibiting the P2Y12 receptor. So it's competing with ADP. And by inhibiting this receptor, it's going to inhibit platelet activation. I do want to take a moment here and talk about this inside-out signaling. We know that when thrombin, ADP, and thromboxane bind their various receptors, that it does trigger platelet activation. But it also triggers inside-out signaling such that this glycoprotein 2B3A receptor that we'll talk about shortly, it goes from a low affinity for fibrinogen to a high affinity for fibrinogen, which is going to be important in platelet adhesion and thrombus formation. That's part of the activation, aggregation, amplification steps. As shown here is the dosing, which is not so critical for our course. Then we have prasugrel, which is another irreversible inhibitor of the P2Y12 receptor, which only undergoes a one-step oxidation process. Additionally, you have ticagrelor, which is an active form of the drug that doesn't need to undergo any oxidation steps, and that actually reversibly inhibits the P2Y12 receptor. It actually does it by allosteric inhibition. So it's not directly competing for ADP at the ADP binding site. It binds at a different site, and it causes a conformational change in the P2Y12 receptor such that the P2Y12 receptor is no longer active. And then cangrelor. We won't say much about this other than the fact that it's a P2Y12 receptor antagonist as well, but it's an intravenous form of these P2Y12 receptors, if you will. It's given IV, and all these medications had to be given orally. We're learning more and more that it's more beneficial to give these patients who need these medications to be given it in a crush form. And last but not least, we have what's called the glycoprotein 2B3A inhibitors. So these bind the platelet glycoprotein 2B3A receptor, so they bind them and they reduce platelet aggregation. And so among the various agents, we have axipamab, epitephametide, and tirofiban. And these form the class of medications that are known as glycoprotein 2B3A inhibitors. Let's move on now and talk about anticoagulant therapy. So we have many options in terms of parenteral anticoagulant therapy. So one to be very aware of is unfractionated heparin. So unfractionated heparin, as we talked about previously, binds to antithrombin, or in this case in this table is referred to as antithrombin 3, resulting in inactivation of thrombin and other clotting factors that we discussed previously. We won't focus too much on the dosing, but I do want to point out that oddly it does activate platelets. I say oddly because it's not a desired effect, but here we're really focused on the coagulation cascade, and that's where it's really beneficial. Another option we have is low molecular weight heparin, also known as enoxaparin. It's also known as dalteparin and comes in a couple other forms, but enoxaparin is the most common form of low molecular weight heparin. And the nice thing about this medication is that it can be given subcutaneously or IV. We talked about how unfractionated heparin is given IV. It's dosed continuously, whereas enoxaparin can be given once a day or even twice a day. And similarly, it binds to the antithrombin to increase its activity, but also inactivates factor 10A. And here's the dosing shown here, and some other features related to the medication that are not so relevant for our course. Now, sometimes we have patients that have an intolerance to heparin, and so we have to think about direct thrombin inhibitors, and the example of that is bivalirudin. And here again is the dosing, and here again is mentioned some features that are more relevant to the cardiac cath lab and not our course. And last but not least, we have fondaparinux, which is a selective synthetic factor 10A inhibitor, and the dosing is shown here. And it's not recommended as a sole anticoagulant during percutaneous coronary intervention for acute coronary syndromes. We really want to make sure we're using agents that have also 2A effect, factor 2A effect. But that's only relevant for fondaparinux. So if you use fondaparinux, you also want to couple it with agents that have anti-2A effect. But really not so relevant for step 1, just something I want you to be aware of. And so we're using not all of these options, one of these options. Similarly, when we're talking about antiplatelet therapy, we're using aspirin plus either clopidogrel or prasugrel ticagrelor. We're not using all of them together. We're using one of them. And sometimes we'll use the glycoprotein 2B3A inhibitors as an adjunct, but that's something beyond the scope of this course. That's a decision that's made by interventional cardiologists, so a specialized cardiologist that's received additional training beyond just training as a general cardiologist. So I want to talk about high-intensity statin therapy, and I want to do it in a way that we have not talked about medical therapy in this course. I want to talk about it in terms of a randomized controlled trial. So a really important randomized controlled trial was a Prove-It-TIMI 22 trial. So this was a randomized controlled trial, placebo-controlled trial, where patients were randomized to standard lipid lowering with pravastatin at a dose of 40 milligrams per day versus aggressive lipid lowering using a medication called atorvastatin at a dose of 80 milligrams per day. So this would be considered a high-intensity statin. This would be kind of considered a low to moderate intensity statin. And so these were patients that were studied that were undergoing or that were hospitalized for an acute coronary syndrome. So they had unstable angina, a non-ST semi-elevation myocardial infarction, or a ST semi-elevation myocardial infarction. And so the outcome of the study that was of interest was a primary composite endpoint. So combined, they looked at death, myocardial infarction, unstable angina requiring rehospitalization, revascularization where you had to have the patient undergo another stent procedure or bypass surgery or a stroke. And they looked at this outcome at a mean follow-up of 24 months. And what we see in this trial is several important points. So when we look on the x-axis, we have time of the visit. So this is baseline all the way out to the final visit. And then we have the LDL cholesterol. And what we find is with the LDL cholesterol, most patients were starting at an average of 106 milligrams per deciliter. What we find with the dose of 40 milligrams of pravastatin that we only got it to 95 milligrams per deciliter. With the 80 milligrams of atorvastatin, we got it to a level of less than 70. We got it to 62 milligrams per deciliter. And so what we see is that not only do we reduce LDL, is that we improve mortality. And that's obvious in this next slide. So we talked again about that primary composite endpoint of death, MI, unstable angina requiring hospitalization, revascularization, stroke, and a mean follow-up of 24 months. But on this graph, what we're looking at is the percent of patients, what we're looking at is a primary composite endpoint here. So there's a percentage of patients achieving that endpoint on this portion of the graph. So what we're finding is that more patients are achieving this outcome, this bad outcome, in the pravastatin group versus the atorvastatin group. And then when we focus just on mortality, all-cause mortality, what we're finding is that patients are living longer when they receive atorvastatin 80. So based on this very important trial, as well as many more, what we now do is we put patients on high-intensity statins, such as atorvastatin, at a dose of 80 milligrams per day when they suffer an acute coronary syndrome because it will make them live longer. And that's mediated by the fact that LDL is reduced to a level less than 70 milligrams per deciliter. So that becomes a goal for patients who suffer an acute coronary syndrome, that we want to get their LDL to a goal of less than 70 milligrams per deciliter, with at least a 50% reduction from where they started. But I will also admit that these statins have what are called pleiotropic effects. They have inflammatory effects that we don't completely understand that also probably contribute to the fact that when you administer them in patients with an acute coronary syndrome, it allows those patients to live longer, particularly if it's a high-intensity statin. So now we come to review question 2. An 82-year-old man is evaluated in the emergency department for chest pain that began 2 days ago. He describes substernal chest pain, which initially was only precipitated by exertion and is relieved by rest. Earlier today, the patient reports several 2 to 3 minute episodes of chest pain at rest that resolve spontaneously. So what you should start thinking about is that this patient is developing an acute coronary syndrome. the patient is having chest pain at rest. On physical examination, the patient's temperature is normal, blood pressure is okay, 142/98. I will admit that's in the hypertensive range. The patient is slightly tachycardic, breathing normally with the oxygen saturation by pulse oximetry of 100% on room air. The remainder of the examination is unremarkable. So the question I ask you now is, which of the following therapies should be administered first and is associated with an improvement in mortality? So which therapy should be administered first and is associated with increased survival? So the options are aspirin, atorvastatin, high-flow oxygen, sublingual nitroglycerin. That's the last option here. So I want you to think about the answer to this question. Pause the video so you can think about that, and then unpause it when you're ready, and we'll discuss it. So the answer we're looking for here is aspirin. Aspirin should be the first therapy that you should administer that's associated with an improvement in mortality. Now, we just talked about the fact that high-intensity atorvastatin is also associated with an improvement in mortality, but we find that aspirin is more beneficial. We want patients to receive that first. Now, what about high-flow oxygen? It makes sense when we think about myocardial oxygen supply and demand that we should think about administering oxygen, particularly if the oxygen saturation is not normal. In this case, this patient's oxygen saturation was 100%. So when I was a medical student, when I was a resident, when I was a cardiology fellow, and early on when I was in attending, and I've only been attending for about 4 years now, I was administering high-flow oxygen. But in 2018, we had what's called a systematic review. That's a meta-analysis. So that was a study of multiple randomized control trials. And what we found is that when we were very aggressive as far as trying to raise that oxygen saturation for patients presenting in the emergency room, now, albeit these were ill patients that had sepsis, critical illness such as stroke, trauma, myocardial infarction, or cardiac arrest, or even emergency surgery, these are the patients that are included. So it was a hodgepodge of a lot of ill patients. And so when we're very aggressive with getting oxygen saturations in the range of 94 to 99%, and trying to get that even higher with oxygen administration, we saw actually there was a signal at 30 days for increased mortality. So that's not well understood, but we did see that there was increased mortality. So it really moved away from that. And what we've said now is that it's reasonable to keep patients, or maybe I should rephrase it and say it this way, it's reasonable to administer oxygen when the oxygen saturation is less than 90%. But maybe not to think about it when the oxygen saturation is 93% or greater. And the sublingual nitroglycerin, while it relieves chest discomfort and it does prevent vasospasm and it does improve coronary supply, it's not associated with an improvement in survival. So we want to think about therapies that are going to make the patient live longer, especially when we think about the pathophysiology of a platelet plug formation that's associated with coronary thrombosis. So let's move on now and realize that we've talked about medical therapy, we talked about anti-ischemic agents, we talked about antiplatelet therapy, we talked about anticoagulation, and we talked about high-intensity statin therapy. So what else can we do for a patient? Well, let's focus on unstable angina and non-ST semi-elevation myocardial infarction. So in this type of patient, we have two options. So let's start off first with this part of the flow chart. So non-ST semi-elevation acute coronary syndrome. So again, that's unstable angina or an NSTEMI. So if that's definite or likely, and we don't want you to worry too much about whether it's definite or likely, we just want you to think, for the purpose of this course, if it's a possibility, there's two strategies to taking care of this patient. One strategy is what's called the ischemia-guided strategy, and the other strategy is called the early invasive strategy. So in the ischemia-guided strategy, we are not going to rush this patient to the cath lab. We're going to think about a non-invasive evaluation similar to what we would consider in a patient that's having stable angina. So you remember in the stable angina team-based learning session, that patient underwent a treadmill stress echocardiogram. So that's a possibility, even in a patient that's undergoing or experiencing unstable angina or NSTEMI, that you choose an ischemia-guided strategy and have the patient undergo a treadmill stress echocardiogram. And so if medical therapy as part of this ischemia-guided strategy is ineffective, or if the stress test detects severe myocardial ischemia, then we want to consider coronary angiography with revascularization. And so that's this early invasive strategy where if patients fall onto the right side of the flow chart, we are really thinking about getting them to the cardiac catheterization laboratory promptly, where they're going to undergo a diagnostic coronary angiogram. We're going to determine whether there is a culprit lesion responsible for the unstable angina or non-ST7 elevation myocardial infarction. So we're going to look and see whether we see plaque rupture or erosion with thrombus formation. We're not really going to see plaque rupture or erosion, but we will see the thrombus associated with that. And in that type of patient, we're going to think about doing what's called primary percutaneous coronary intervention, where in that case, if feasible, we'll go ahead and place a stent. But remember, this is in the background of all the therapies that we talked about already. Now, how the heck do we make the decision between an ischemia-guided strategy versus an early invasive strategy? Well, that thinking is based on the likelihood that the signs and symptoms that the patient is undergoing represent an acute coronary syndrome due to coronary artery disease. So we have high likelihood features, we have intermediate likelihood features, and we have low likelihood features. So when we're thinking about high likelihood features, we're going to think about the history. So is it chest or left arm pain or discomfort as a chief symptom reproducing prior documented angina? So if a patient had a prior myocardial infarction and is coming to the hospital with the same type of chest pain, we're going to take that very seriously. So there's high likelihood that the signs and symptoms represent an acute coronary syndrome due to coronary artery disease. Then we're going to think about exam. Do we hear a transient mitral regurgitant murmur? Is there hypertension? Hypotension? Is there diaphoresis? Is there pulmonary edema? Is there crackles? Then we're going to look at the EKG. And really what I want you to think about is there ST segment deviation? Is there ST segment depressions? Are there new T-wave inversions and multiple leads? And of course, we're going to look at the cardiac biomarkers. Are they elevated? And then we have the intermediate likelihood category, where we're looking to see if chest or left arm pain is a chief symptom. Is it an older patient? Is it a male patient? Is it a diabetic patient? Is it a patient that has extra cardiac vascular disease, whether that's peripheral arterial disease that you'll learn about or a prior history of stroke? Does that patient have fixed Q waves that might suggest they had a myocardial infarction in the past where they may not have had symptoms? Does a patient have ST segment depressions that don't quite meet the threshold of being worrisome? And in this category, the patient has normal cardiac markers. And then we have the low likelihood category, where these are patients where the symptoms are not really adding up. They may have had recent cocaine use, so drugs may mimic the symptomatology. On examination, they may have chest pain that's reproducible palpation, where you're thinking maybe about a musculoskeletal possibility. And then they have non-specific findings on the ECG, such as T-wave flattening, or they have ST segment, really T-wave flattening. And the cardiac biomarkers here are normal. In addition to that, we have risk models that actually really think about when we're taking care of patients. We'll actually calculate it and put it in our note and document it in the hospital. And so we have the GRACE risk score, where if we look at various parameters such as age, heart rate, blood pressure, kidney function, whether they're in a severe form of heart failure, if they have ST segment shifts, and other parameters as shown here, if that score is 140 or higher, that suggests that patient is at high risk to have bad outcomes, particularly in terms of mortality. And so we'll really think about an early invasive strategy for that patient. Another risk score is a TIMI risk score, where we look at all these parameters as listed here. And if your score is 3 or higher, that's considered high, where we really want to consider early invasive strategy. But the reality is that initial table I showed you, where we said the percent 1-year mortality has really declined for for NSTEMI, that's really been driven by the fact that more and more patients are undergoing an early invasive strategy. So less patients are undergoing this ischemia-guided strategy, because I haven't mentioned that there's a possibility in this ischemia-guided strategy that if a patient is able to tolerate medical therapy without any symptoms and the stress test does not show high-risk findings, that the patient does not end up in the cath lab. And we presume that they have a myocardial infarction if the cardiac biomarkers are up, or we presume they have unstable angina, and just treat them with all the therapy we talked previously. Again, we moved away from that because we want to document whether they do have coronary arteries with a coronary angiogram, and then there's interventions that we can take that can really be beneficial for that patient. Now, this is in contrast to a STEMI. And so we talk about primary percutaneous coronary intervention versus fibrolytic therapy. And so remember that much of America is rural, and a patient may not live next to a hospital where there's an interventional cardiologist like myself that has a cath lab or cardiac cath lab where they can do a percutaneous coronary intervention in the middle of the night. So if a patient who is a potential candidate for reperfusion presents, and if they present at a PCI-capable hospital, then we're going to get them to the cath lab right away. And our goal is from the time of first medical contact to the time a device is used in that artery to open it up, that time has to be 90 minutes or less. And we're scrutinized very carefully as interventional cardiologists to make sure we meet that time or threshold. So we're going to do an angiogram, a cardiac catheterization procedure, to document whether there is a blockage that is consistent with a STEMI. And in rare situations, we'll think about medical therapy. Most commonly, we'll think about percutaneous coronary intervention, and rarely we'll think about CABG surgery. And that has to do with the fact that we think about CABG surgery when patients have multivessel disease, but definitely there's going to be a culprit lesion, one vessel that's responsible for that STEMI. And if we wait to do CABG surgery, there can be delays. We can mobilize very quickly, very rapidly when we're thinking about percutaneous coronary intervention. But again, if we think about rural areas, patients sometimes present at a non-PCI capable hospital. So a decision has to be made. We talk about door in, door out time. That door in, door out time has to be less than 30 minutes. So we can think about getting a patient to a hospital by ambulance or helicopter to undergo primary PCI. But we have to do that if we think it's realistic that from the time of first medical contact to device time to open up that artery, that has to be 120 minutes or less. If that's not realistic, then we want to think about fibrolytic therapy. And that needs to be administered within 30 minutes of arrival of that hospital. We want to think about door to needle time as compared to door to balloon time, or door to balloon time here, door to needle time. So putting in that IV and administering fibrolytic therapy. So fibrolytic agents include streptokinase and tissue plasminogen activator, or altipase, which, as the name suggests, being fibrolytic agents, they bind fibrin and they promote its degradation. And by doing that, we can lyse that clot in that coronary artery and restore blood flow. But one thing that we really want to emphasize is that even if it's likely that fibrolysis will be successful, and success is measured by the fact that the ST segments resolve by greater than 50% at 60 to 90 minutes after getting the fibrolytic therapy, sometimes patients will get what are called reperfusion arrhythmias. There's some classic ones that we may touch on if we see that. And there's, of course, disappearance of chest pain. Those are things we're looking for. And even if those things happen, we want to get them to a PCI-capable hospital in case complications could develop. And so that's what all these yellow boxes are really aimed at, is that we want to get them back to a hospital, or get them to a hospital that can perform PCI if necessary. Because early success doesn't necessarily mean that there'll be continued success. Now here's another figure just showing the early phase of STEMI, and just emphasizing that we really want to think about primary PCI, so meaning doing percutaneous coronary intervention right away. If they're not able to get there, then we're really going to think about fibrinolysis therapy, or if it's not possible, that hospital. And then we're just going to be really cognizant of the fact that if there's a delay, then fibrinolytic therapy or fibrinolysis is not going to be as successful. So that's really important to think about and remember, is that we want to administer fibrinolysis therapy early on. For the purpose of this course, that timing is not important for you to be aware of. And now I want to move on and talk briefly about the fact that there are other forms of mechanical revascularization, and that's really in the form of CABG surgery. So approximately 5 to 10% of non-ST segment elevation ACS, so we're talking about unstable angina or NSTEMI, require CABG based on the criteria that we talked about in previous lectures. And these represent actually a challenging subgroup given their high-risk characteristics compared with patients undergoing elective CABG in the setting of stable angina. So in that context, let's briefly compare PCI versus CABG surgery. So PCI, the advantage of that is it's short recovery. We can do it very quickly. Patients get out of the hospital the next day typically. The other advantage is there's a low risk of stroke associated with that procedure. But one disadvantage is the fact that there's an increased risk of target vessel revascularization. What the heck does that mean? That means in the vessel where we put in that stent, and within that stent, what happens is that we don't necessarily have as a durable result as compared to CABG surgery. So that's a disadvantage of PCI, is that a patient may require another stent procedure down the road sooner as compared to if they underwent CABG surgery. Now, the advantages of CABG surgery are that very fact, that there's less risk of target revascularization. There's longer patency of those grafts. The disadvantage is that there's longer recovery. It takes a week or two to fully recover, and sometimes months to really recover from CABG surgery. There's also a higher risk of stroke when a patient is put on a cardiopulmonary bypass machine. Sometimes a surgeon is able to do CABG surgery in a minimally invasive way, and they can mitigate that risk by not putting a patient on a cardiopulmonary bypass machine. But I also want to talk about another potential benefit of CABG surgery. We talk about CABG surgery being revascularization of an entire territory, not just a vessel. What do we mean by that? If we're talking about the pediculema, so that refers to left ventral memory artery, pedicle meaning it's just arising from a subclavian artery as it normally should, and the distal portion is put beyond the stenosis and the distal portion of the left anterior descending artery. What's wonderful about this is that we are bypassing all the disease. Not only are we bypassing the flow-limiting lesion, we're also bypassing non-flow-limiting lesions that may progress over time, even with medical therapy. So that's why, in part, the bypass is beneficial, is that we're bypassing all of that disease, not only the severe disease that prompted the bypass surgery in the first place, but also the mild to moderate disease. Whereas with the stent procedure, we want to sometimes limit the amount of scaffold, the amount of stent in that artery, for reasons that are not important in this course, but it can be advantageous to do that. But what happens if we stent the most severe lesion and leave alone the mild lesion? What can happen is disease can progress over time. But the issue is that if we put in a stent when the disease is not severe, that puts a patient at risk to have complications of a stent procedure. So we don't want to do that if it's not necessary. So that's the disadvantage of PCI, is that disease can progress over years in this area as compared to CABG surgery, where the bypass grafts have gone distal to the vessel anyway. Now let's spend some time and talk about the complications associated with a myocardial infarction. So this really focuses in more on STEMI population, a transmural infarct, but certainly patients that undergo an NSTEMI can also experience this. But this is different than unstable angina because only NSTEMI and STEMI patients have experienced a myocardial infarction, where there's actually myocardial necrosis. So with a myocardial infarction, there are several things that can take place. So with a myocardial infarction, what can happen is that there is injury to the ventricular myocyte where there's necrosis. And so adjacent to that wall that's involved, what can happen is that there can be akinesis, meaning that segment of the left ventricle is not moving well. And what happens when that segment of the left ventricle is not moving well? Blood adjacent to it becomes stagnant. And then when it becomes stagnant, what can happen is clot can form. And that clot that forms along that wall can then embolize to the brain and other parts of the body. and cause a stroke or systemic embolization. So embolism is a potential complication of myocardial infarction. Now, when we have a myocardial infarction, we also have a decrease in contractility by definition, and that's going to increase stroke volume. And if there's going to be a decrease in stroke volume, so a decrease in contractility and decrease in stroke volume, ultimately there's going to be a decrease in cardiac output. And with a decrease in cardiac output, there is going to be hypotension. And with the hypotension, there's going to be a decrease in coronary perfusion pressure. We said that's diastolic pressure. And that's going to increase myocardial ischemia. And in the setting of myocardial infarction, having increased myocardial ischemia is going to cause more contractile dysfunction. And it's going to cause this vicious cycle where patients can develop what's called cardiogenic shock, which we'll talk about more later in this course. In addition, patients with myocardial infarction can have electrical instability. They can suffer arrhythmias, as we'll learn about also later in this course. They can develop ventricular tachycardia. They can develop ventricular fibrillation, together known as ventricular tachyarrhythmias. In fact, out of the hospital, that can be their presentation before they're brought into the hospital. They can have a cardiac arrest with myocardial infarction associated with electrical instability that's caused that patient to have an arrhythmia. But patients can also arrhythmias that are better tolerated, such as atrial fibrillation, which also, again, we're going to learn about later. But what we really want to pay attention in this lecture is tissue necrosis. So you have myocardial infarction and tissue necrosis in the ways that we will talk about shortly. And that tissue necrosis can cause papillary muscle infarction and ischemia that can cause mitral regurgitation. And with mitral regurgitation, we can get congestive heart failure. With tissue necrosis, we can also get a ventricular septal defect. So the wall that divides the left ventricle and right ventricle, if the coronary artery that supplies the interventricular septum is involved, and a patient has a dense myocardial infarction that results in tissue necrosis, a defect can develop. There can be necrosis such that there's a communication. That wall is ruptured from the wall that divides the left ventricle and right ventricle is ruptured. Patients also can develop inflammation, known as pericarditis, which we'll also talk about, which can be complicated by cardiac tamponade. Also, when we have rupture, we talk about the interventricular septum. In comparison to that, you can have rupture of the free wall, which also can result in cardiac tamponade, as we'll discuss shortly. So myocardial infarction complications. So let's talk about this in slightly more detail. So one complication that I want you to be aware of is what's called post-infarction fibrinous pericarditis. I want you to pay attention to the onset. It occurs within the first few days post-MI. It's going to be really important because you will definitely get questions on step 1, describing a patient clinical scenario where you have to think about what that complication is and if it's the appropriate onset for that complication to take place. The reason these questions are used on step 1 is that they're 2 3-step questions which step 1 likes to utilize because they're more difficult, more conceptual questions that really not only test medical knowledge, but the application of that medical knowledge. So it's important to remember that when a patient has fibrinous pericarditis, that can be very easily be treated with high-dose aspirin and colchicine that are treating the anti-inflammatory properties of that myocardial infarction that are responsible for the pericarditis. So patients will often report chest pain, particularly when in particular positions, as you'll learn more about in your pericarditis lecture. Oftentimes when they cough, they'll report having a chest discomfort. And on exam, the patient will have a pericardial friction rub. Now moving on, patients can have a papillary muscle rupture. This usually occurs 2 to 7 days post-MI. And this is mediated, as we talked about, by myocardial infarction resulting in ischemic necrosis and rupture of a left ventricular papillary muscle that may be rapidly fatal due to acute severe mitral regurgitation. So it's important when we have papillary muscle rupture, that's going to result in severe mitral regurgitation, and acutely in many patients that's not well tolerated, and they can develop heart failure and even death. We talk about how the posterior medial and the anterior lateral papillary muscles. And it's the posterior medial papillary muscle that we get most concerned about because it has a single coronary artery supply, typically the right coronary artery, and that can be associated with papillary muscle rupture and this phenomenon as we just mentioned. Now, interventricular septal rupture, that occurs 3 to 5 days post-MI. That's mediated by microphase degradation resulting in a ventricular septal defect and a right to left shunt. I want you to pay attention to 3 to 5 days, and kind of what's happening at the histological or microscopic level is relevant because the degree of necrosis is what mediates the damage and ultimately the complication. Now, shown here is a papillary muscle rupture here. So you see that one of the papillary muscles has ruptured, and that's, again, shown in this diagram. It's probably the anterior lateral muscle as opposed to the posterior medial one. Moving on now, in terms of mechanical complications, we have a ventricular pseudoaneurysm that occurs 3 to 14 days post-MI. It is defined as a contained free wall rupture which can be associated with mural thrombus that can embolize, arrhythmias, and heart failure. A ventricular pseudoaneurysm is shown in this figure, where we have full thickness rupture of the left ventricular free wall, but the issue is that the blood is contained within the pericardium. The reason why the blood does not extend throughout the entire pericardium is that frequently with a pseudoaneurysm, it's lined by thrombus to limit the extent of the bleed. This is in contrast to a ventricular free wall rupture that occurs 5 to 14 days post-MI. Ventricular free wall ruptures are infrequent, but they're a deadly complication. They are defined as a rupture of the LV free wall through a tear in the necrotic myocardium that results in sudden death or tamponade. A ventricular free wall rupture is shown in this figure, where again we have free wall rupture of the left ventricle such that there can be bleeding around the left ventricle and right ventricle within the pericardial space that can result in hemodynamic instability with tamponade physiology, as you'll learn more about in your pericardial disease lecture. Additionally, a true ventricular aneurysm occurs several weeks to months post-MI. It develops as the ventricular wall is weakened but not perforated by the phagocytic clearance of necrotic tissue, and it results in a localized outward bulge, which we refer to as dyskinesis, when the residual viable heart muscle contracts. So if this was a left ventricle and this is a free wall, this would be an aneurysm, a bulge. Frequently, we see a bulge at the apex, and that's shown here if this is left ventricle. Please excuse my abilities as an artist. Unlike a pseudoaneurysm described earlier, a true aneurysm does not involve communication between the LV cavity and the pericardium, so that rupture and tamponade do not develop. So in terms of mechanical complications now, we've talked about a ventricular pseudoaneurysm, a ventricular free wall rupture, and to some degree, a true ventricular aneurysm. Remember, a papillary muscle rupture as well as an interventricular septal rupture are also two other forms of mechanical complication. And last but not least, we have a couple other complications to talk about. Dressler syndrome, which occurs several weeks post-MI. This is a rare form of pericarditis, which occurs weeks following an MI. The etiology is unclear, but it's certainly related to an immune-mediated process. Thromboembolism, we talked about how that can be associated with a pseudoaneurysm or a free wall rupture. And these occurs 5 to 14 days post-MI. We talked about how it's caused by stasis of blood flow in regions of impaired LV contraction after an MI, especially involving the apex. That's in fact shown here. This is the left ventricle. This is the anterior lateral wall. This is a septum, and this is apex where we have thrombus in that area. And again, this can embolize. And of course, we get concerned about heart failure with pulmonary edema. So with a weakened left ventricle, what happens is a decreased contractility, and with a decrease in contractility, there's a decrease in cardiac output and ultimately heart failure symptoms, as you'll learn about. And this can occur acutely to months or even years post-MI. And it's caused by infarction of the left ventricle and could be the consequence of any complication of MI, such as a free wall rupture, as we talked about, or even a pseudoaneurysm, but it doesn't have to be associated with these mechanical complications. And again, mechanical complications are characterized by myocardial necrosis caused by the myocardial infarction. And the classic examples are really the ventricular septal defect, a papillary muscle rupture, free wall rupture, a ventricular pseudoaneurysm. Those would be the classic examples. Now, myocardial infarction, evolution and pathophysiology. I don't want to spend too much on this slide because you got into this in your pathophysiology. I will just say a couple things here where within the first 24 hours, what we find grossly is we see dark mottling if we were looking grossly. And what we see with an acute infarct approximately 12 hours old already is that it starts to show contraction band necrosis. You've heard of this, contraction band necrosis with nuclear karyolysis, focal hemorrhage, and an absence of inflammation. And now, what I really want to emphasize, what's unique about the myocardium is this idea of reperfusion injury. So when you have myocardial injury resulting in myocardial infarction, we have continued blood supply to some degree, and so there's reperfusion injury. There's reactive oxygen species that generate, and then you see this very characteristic form of necrosis referred to as contraction band necrosis. So this is a type of uncontrolled cell death, necrosis, that's, again, unique to cardiac myocytes and thought to arise in reperfusion form from hypercontraction, which is a result of the sarcolemmal rupture. So rupture of the ventricular myocyte cell membrane. And here you see the again, contraction band necrosis. And what we see in the first 24 hours is ventricular arrhythmias, heart failure, and even cardiogenic shock. Now, days 1 to 3, what we see grossly hyperemia. So that might look pale here, hyperemia. So there's now increased blood flow to this area by local mediators. But specifically, an acute infarct, approximately 24 to 40 hours old, demonstrates coagulation, necrosis, and dense infiltration of neutrophils. And that's seen here on histological section where you see a lot of purple here. And that's what the hyperemia is allowing to happen, is that now it's going to be dense infiltration of the neutrophils. And that's why in this time frame, you start to see post-infarction fibrinous pericarditis. We have inflammatory cells that are meeting that pericarditis process. Now in days 3 to 14, what we see is a hyperemic border, which may be a central yellow-brown softening in color. So a healing infarct approximately 10 days old shows granulation tissue with new blood vessels, which we refer to as neovascularization, mild chronic inflammation consisting of macrophages and lymphocytes, fibroblasts, and early collagen deposition. And what we see here on a histologic section is that there's a small segment of viable myocardium here in the upper left here. See, this is viable myocardium, and this is the rest of it. And so this is a time frame where we can see free wall rupture with tamponade. We can see papillary muscle rupture that is going to result in mitral regurgitation and interventricular septal rupture. So we're going to see a lot of those mechanical complications. You wouldn't expect them to show up within the first hour after the patient had the onset of the symptoms due to a myocardial infarction. Again, I want to really emphasize that it's dense myocardial infarctions, transmural myocardial infarction that are really going to result in these mechanical complications. And so last but not least, 2 weeks to several months later, if you could look at the myocardium, it will look gray and white in color. And the healed infarct, approximately 1 to 2 months old, shows dense fibrosis. The inflammation in new vessels that had formed previously have largely regressed. You have a viable myocardium present in the upper left here as well. And again, all of these are H&E images here that I want you to correlate. So I hope going through this briefly will help you in your review for step 1 when you get to that point. Okay, coming full circle with acute coronary syndrome. So you saw this table. You saw the percent 1-year mortality, and you saw 1996 over to 2014, and you saw how there's a decline first in terms of the STEMI population, and that's shown in blue here. As far as aspirin, heparin, fibrolytic therapy, that was some of the initial improvements we saw. And then high-intensity statin, we'll learn later when patients develop heart failure from a STEMI that ACE inhibitors are very important, angiotensin-converting enzyme inhibitors. We also learned about PCI and stent placement procedures. We learned that routine PCI, bringing patients to the cath lab right away when possible, at a PCI-capable hospital is important. So think STEMI, PCI, get them to the cath lab. We don't go STEMI CABG surgery. We do STEMI, coronary angiogram, and in rare instances do we think about CABG surgery for a STEMI. We made some advances with clopidogrel, prasugrel, and ticagrelor. And again, that's why we see the changes we see. Now with an NSTEMI, and to some degree we're referring to unstable angina here, the same theory is helpful here, but this graph is specifically referring to NSTEMI. We saw improvements with aspirin, heparin, also low molecular weight heparin. We saw improvements with statin and ACE inhibitor again. We saw this idea of routine early invasive treatment, getting these patients to the cath lab sooner rather than later is very important and helpful. It provides a survival benefit. Clopidogrel and to some degree fondaparinux and ticagrelor all have contributed to these benefits. So our take-home messages: acute coronary syndromes. Okay, so take-home message number 1. Acute coronary syndromes include unstable angina, non-ST segment elevation myocardial infarction, NSTEMI, and ST segment elevation myocardial infarction, STEMI. So you got to know what acute coronary syndromes are. And we distinguished unstable angina from an NSTEMI by the fact that in an unstable angina scenario, we do not see cardiac troponins elevated because myocardial infarction is not taking place. Most ACS episodes are precipitated by intercoronary thrombus formation at the site of plaque disruption, which occurs in 2 major forms. We talked about plaque rupture, which is by and large the most common, and then plaque erosion. Plaque rupture is more common, and plaque erosion. The diagnosis of specific types of ACS relies on patients' history, ECG abnormalities, and the presence of specific biomarkers in the serum. For example, high sensitivity cardiac troponin T. So you'll hear a lot more about the old assays on your exams because that is what is on step 1. On your quizzes, we'll talk more about high sensitivity cardiac troponin T. And then when you get into your 3rd year and 4th year, certainly all you're going to hear about is really high sensitivity cardiac troponin T. And then the acute treatment of ACS involves anti-ischemic therapy to restore the balance between myocardial oxygen supply and demand, antithrombotic therapy to facilitate resolution of intercoronary thrombus, high-intensity statin therapy, and prompt mechanical revascularization, particularly in the setting of STEMI. I want to put a shout out or take a moment here to promote my own website, tinyurl.com/UCDcards. Many of my lectures here for your course show up here, but I also have other lectures I provide to residents and fellows and interventional cardiology fellows if you're interested. Again, tinyurl.com/UCDcards. Please take a look when you have a moment. And again, thank you. This lecture was much longer than the allotted hour that it would have been given in real time. I think it's a really important topic. Again, I apologize. There's a pattern in me where I've gone in a little longer than allowed because I really wanted to give you a detailed explanation of these topics. I would say that a lot of the topics I went through are review related to stable angina or stable coronary artery disease. And certainly the last few slides were things that you would learn about in your pathophysiology course, particularly when we talked about the H&E stains. So with that said, I'm all done, and I appreciate your patience. Thank you so much.